Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Webinar Series. This presentation tonight is titled Common Acute Injuries of the Knee. And our presenting provider is Kristopher Aalderink, an orthopedic surgeon who is also fellowship trained in sports medicine. Dr. Aalderink sees patients at our Schoolcraft campus location. Welcome, Dr. Aalderink.
Thank you. Good evening. Welcome to everyone for the tongue twister, the Wednesday Wellness Webinar. I guess I'm your host this evening, so thank you for taking time out of your busy and snowy day to learn a little bit about the knee tonight. And I'm hopeful that by the end of the session this evening, you will be much more knowledgeable about common knee injuries, specifically when to seek help and what you can do about it. I don't know how many of you probably felt like this, like I did today, getting out of work as I was watching things coming down. I'm sure that there are a few of you that feel more like this and are celebrating finally some snow. For those of you that thought we were going to make it out alive without a heavy snowfall, I guess this is Michigan. I know I got home, and after shoveling the driveway a couple of times as it was coming down hard, I felt a little bit more like I wanted to do this. But all hope is not lost. We can look forward to Groundhog Day coming up, and hopefully Punxsutawney Phil will have good news for us, and this will be a small blip on the radar going forward. A little bit about me, my background. I was born in Grand Rapids, Michigan, actually just a suburb of, in Jenison, Michigan. I went to the University of Michigan for my undergraduate training, graduating with a degree in microbiology. I then went to medical school at University of Michigan as well, where I spent another 4 years in training. Following medical school, I went down the street to Henry Ford Hospital and did a 5-year orthopedic surgery residency. And then following that, I chose to do an additional 1 year of specialization working at the University of Iowa in a sports fellowship, working closely with the University of Iowa athletic department and sports teams. I currently practice out of the Trinity Health IHA Medical Group Medical Center on Schoolcraft campus in Livonia. My partners directly are myself. I'm the sports medicine specialist. My partner, Dr. Brian Pack, is our joint replacement surgeon, and he focuses mostly on hip and knee replacements. Dr. Neil Bakshi is our fellowship trained foot and ankle surgeon, so he will handle everything sort of below the knee. And then in addition, there are 2 providers that are orthopedic hand surgeons, meaning they did a fellowship in hand surgery, that are also part of IHA, also working out of this Livonia Medical Center, Trinity Health Medical Center, Schoolcraft campus. The medical center itself is located right off of 275, kind of at the 275 and 7 Mile exit. So it's fairly visible. It's next to the big sports dome. And again, like I said, it's right on Schoolcraft campus. We offer a lot of services at the Livonia Medical Center. So we have an ambulatory surgery center right there, and I serve as the medical director of that surgery center. There are currently 4 operating rooms with potentially a capacity for 5 at some point. So a lot of the surgeries I do are predominantly at that facility. There's also an urgent care in the building. So if you need something urgent, especially after hours, that's a good location and a good option for you. In addition to orthopedic surgery, we have primary care, pediatrics, obstetrics and gynecology, podiatry, urology, vascular surgery, plastics and reconstructive. Within the 4th floor, we call it our musculoskeletal center. And the whole idea is that it's more of a collaborative center where orthopedic surgeons can work alongside podiatry, spine surgery, physical medicine and rehabilitation, physical therapy, to be able to have open communication and help deliver the best care we can to our patients. And as you might know, I mean, a lot of our patients do require specialty care from a number of different specialties. So it's a great opportunity to be able to have that collaboration, to talk together to make sure we're on the same page. There's physical therapy right in the building, as well as imaging capabilities. We have X-ray in our own office, but there's also MRI and CT on site, and there's even a lab, so you can get blood draws for your routine annual blood draws through your primary care physician as well. Not too far, you'll see the picture on the left here. The Trinity Health Medical Center has got the purple arrow in the background, but just down the street is the Trinity Health Elite Sports Center. And this is a indoor sports facility, mostly directed toward a lot of club teams, volleyball specifically. And you can see the picture on the right showing different courts that are available. There's a track and the sports dome is in the background. It's kind of ironic. This was not planned at all. But I have a twin brother who's an architect, and he actually helped design this building. Unbeknownst to each other, he had no idea that I was planning to eventually move out to this new facility and be the medical director. And I had no idea that he had an involvement at all with the Elite Sports Center. So it was sort of funny realization as the project moved along. In addition to being an orthopedic surgeon, I also volunteer time as a team physician. I currently stand on the sidelines for Livonia Churchill, Franklin, and Stevenson high schools. I also provide services for the Livonia City FC as well as Schoolcraft campus. And prior to that, for the previous 10 years, I was the team physician for Plymouth, Canton, Salem high schools, Saline High School, and actually Concordia University, Ann Arbor. So I've got almost 14 years now of volunteer experience standing on the sidelines, treating a lot of our younger athletes as well. So I think, one of the big questions that a lot of people have is, what is an orthopedic sports medicine surgeon? Specifically, like, what do I see? And I treat a lot of injuries involving the shoulder, the hip, and the knee. And that's obviously what we're going to focus on tonight, is more talking about some common knee injuries. A lot of you may be saying, oh my goodness, a surgeon, I don't want to go see a surgeon. When you're a surgeon, that must mean you have to use a scalpel. He's going to do surgery. And I want to reassure you that as a sports medicine specialist, I am greatly poised to be able to determine when surgery is necessary and when it is not. I will reassure you that the overwhelming majority of my practice is non-surgical, and it may involve injections, certainly involves physical therapy. And really the whole idea is I'm there as a coach. I'm there as a coach to help get you back to the level of activity that you want and the quality of life that you deserve. So I can help to orchestrate a lot of those things. So again, let's get into the talk tonight, talking about some common acute knee injuries. When should I see an orthopedic surgeon? I think some of these, are common symptoms that we'll see, and a lot of these will signify something that may be more urgent or more pressing. So anytime you're doing something and you feel a pop, if you get rapid swelling afterward and within a few hours later that night, if after this injury you can't stand on the knee or it's intense pain, we're not talking about sore like a bump or a bruise, but intense pain where you feel like you need to take pain medicine for it. And certainly if the knee looks deformed, if it just doesn't look right, this is not what my knee normally looks like. Early on, we recommend using things like anti-inflammatories as well as icing. That can at least get you through that initial period if you experience some of these symptoms. But certainly if you feel this, these are the cases where we definitely would prefer to see you in the office evaluation. If you find yourself after hours on the weekend, are a number of Trinity Health IHA urgent care locations around the area of Southeast Michigan. I've got a bunch of them listed here for you, showing on the map where they are. Again, our Trinity Health IHA urgent care through the Livonia Medical Center is sort of upper right over here. But as you can see, as you go south, certainly toward Canton, up toward Brighton, Ann Arbor, and even south of Ann Arbor, there's a number of IHA urgent care locations to help take care of you, at least get you through until you can get in to see us. So for the common acute knee injuries tonight, I thought I'd talk a little bit about tendinitis, since this is common. Knee bursitis, talk about what is bursitis and how you can treat it. Meniscal tears are extremely common as we go through life. And so I think that'll be important to talk about. We'll talk briefly about some ligament injuries, tendon ruptures, and then injuries involving the kneecap, fractures and dislocations. I am a sports medicine specialist. I do not do any joint replacement as part of my practice. I defer those to my partner, Dr. Brian Pack. So when we talk about tendons, what is a tendon? A tendon is really defined as a tissue that connects muscle to bone. And so when we look at the knee, I've got some purple arrows here. The common knee tendons are the quadriceps tendon right in the middle, attaching to the top of the kneecap. A lot of people hear about the IT band or the iliotibial band running on the outside portion of the knee. We've got the patellar tendon, although it's technically a ligament, because as you can see on the diagram, it connects bone to bone, not muscle to bone, but a lot of times people refer to it as the patellar tendon. And then the hamstring tendons, there are 3 that kind of come down on the inside of the knee, as well as an additional one on the outside of the knee. Tendons are really made up of something called collagen, and collagen is sort of like the cotton that makes up thread and the thread that makes up fabric. So when we talk about tendinitis, we're really talking about inflammation of the lining of these tendons, inflammation of these bundles that make up these tissues. And it's, a lot of times tendinitis is like a fire. Things are inflamed, things are on fire. What are some different causes for tendinitis? Certainly, overuse injuries is one of the common causes, and I'll see a lot of this in my younger athletes training through high school and college. Sometimes it's a sudden change in activity, right? So January, new year, everybody wants to get in shape and shed some pounds, get rid of that COVID-19, decide to do a couch to 5K program. So if you try to do something too fast, too soon, your body's not ready for it, that can lead to tendinitis. Improper training, sometimes it's running on hard surfaces, sometimes it's easier to start out running on a treadmill, running on a softer surface and working your way up and sort of easing into different environments. Changes in footwear. A lot of what I see that causes knee problems actually comes from further downstream at the foot and ankle. And so people that have either really flat feet or really high arches, that can sort of set you up for problems at the knee. And so orthotics may be useful to help correct some of those problems. Certainly running with good supportive shoes is very important. It's sort of in the running world, and I'm a runner, we oftentimes talk about changing out your shoes every 300 miles or so, just because the natural padding in the shoes eventually breaks down, and it can lead to more force being transmitted to your foot and therefore up to your knee. There's been some recent interest in barefoot running as well, and it's probably beyond the scope of this talk, but in general, a lot of these things can cause tendinitis. What are the common symptoms of tendinitis? So a lot of times increased pain with activity that usually gets better with rest, stiffness, loss of motion. So when that tendon gets inflamed, it tightens down. It doesn't want to stretch. It doesn't want to expand. So that leads to stiffness. Sometimes you'll get a crackling sensation when you push over that tendon, almost like Rice Krispies in and around the knee. Swelling is common, some swelling, not profuse, rapid swelling, but low level of swelling. People will sometimes say it feels warm, feels hot to the touch, and that's just from increased blood flow to the area because of that inflammation. And then a lot of times the common symptom is weakness, this weakness in that muscle tendon group, because as that muscle contracts and tugs on that inflamed tendon, it causes pain. So most of the time the weakness is pain related. General treatment options for tendinitis, we sort of talk about this mnemonic RICE. So rest, ice, compression, elevation. When it comes to icing, we typically say don't ice for more than 15 to 20 minutes at a time. Try to avoid putting the ice directly on the skin. It's good to use some sort of a sleeve, towel, washcloth. Compression, an ACE bandage, an elastic compression sleeve can help sometimes with swelling and stability and support. And then elevation. In general, to be effective, we really talk about trying to get the knee above the level of your heart. So if you're sitting, your knee is well below your heart. You really want to be able to prop it up to help calm things down. And I think that's a really good initial starting point, the RICE that most people can do on their own at home. A lot of times with tendinitis, physical therapy can be very useful and helpful to help to calm things down and actually help to rebuild muscle tendon strength as things do start to improve over time. What about bursitis? What is a bursa? A bursa is basically, it's a cushion. It's a sack or a cushion that sits around the knee. And there are 4 main bursas around the knee. And the picture on the far left showing those. The most common one by far that we'll see problems with is the prepatellar bursa. This basically sits on top of the kneecap, between the skin and the kneecap. Now, most of the time, you shouldn't be aware of the bursa. It shouldn't cause any problems. You shouldn't be able to see it or feel it. It's only when that bursa gets inflamed and swells up that you can start to notice it. Who gets bursitis? I'll see this a lot in my high school and college athletes because they, especially in wrestlers, spending time on your knee, that friction as you're rubbing around between the knee and the ground, that can cause inflammation of that bursal sac and cause it to fill up with fluid. I'll see it in a lot of trades, people that, carpet layers, people that work on their hands and knees a lot, masons, landscapers. But we'll also sometimes see it traumatically. In fact, I saw somebody today, I had asked her if I could use her as an example in my discussion this evening. She had fallen on the ice and landed on the front part of her knee. And sometimes that quick traumatic blow will cause the knee to swell up as well. This is typically what a prepatellar bursitis looks like. You look down and it's almost like you've got a golf ball on your knee. You've got this big pocket of fluid sitting right over the knee. Most of the time, it's more of a cosmetic thing and it doesn't cause problems unless you put pressure on it. So in general, for treatment, we recommend anti-inflammatories to help calm down the inflammation, because as you put that fire out, it allows your body to resorb a lot of that fluid. Gentle compression can help encourage that resorption of fluid. But to really be effective, it needs to be something that you keep on your knee for the most part around the clock. If you put it on for a few hours and then take it off, it doesn't take long for that to fill back up again. Icing can be very helpful to help calm down inflammation as well. And then a lot of it is discussing, how to modify your activities to prevent further aggravation. Kneeling on the knee is something that will definitely be pouring gas on that fire and kind of keep this process going. So we try to recommend avoiding any direct kneeling on the knee. Sometimes if the bursa has been there and been inflamed for a long period of time, there are instances where we can put a needle into it and draw that fluid off. But doing that alone oftentimes is met with disappointment as the fluid reaccumulates. So the key is, if you're going to do that, really doing it in tandem with anti-inflammatories, ice, compression, and some activity modification. The one time that we worry is when we get an infection. So if you notice that you've got swelling on the knee, you start just not feeling well, overall general malaise, fevers, chills. If the knee starts to look really red and angry like this, any type of movement, that can be a sign that there's an infection and bacteria got into that bursa. Then that's more of an emergency. That's more of a surgical emergency, where the treatment for that is to wash things out, get you on some antibiotics to get you to feel better. We'll go from that into the meniscus. The meniscus is something that a lot of people hear about and talk about. The meniscus itself is made of cartilage. And the meniscus, there's two discs of meniscus, really on C-shaped, if you will, on the inside of the knee and the outside of the knee. And the function of the meniscus is shock absorption, like a spring, like the shocks on your car. As you put pressure on the knee, as you just do normal day-to-day activities, whether or not it's walking, jumping, or running, the meniscus tries to take that force and spread it out, to take it away from the bone, away from the cartilage. For those engineers in the office, engineers in the audience rather, here's the formula for hoop stresses. So basically the meniscus works by a series of structures or fibers that run within the meniscus, that as you load it, as it tries to expand out of the joint, these fibers help to pull things back in. And so the hoop stress equation is there for you, and I promise the math checks out. When we talk about the blood supply to the meniscus, a lot of you may have seen this on the internet talking about things like the red zone, the white zone, the red on white zone. And so what that's really talking about is the blood supply. The blood supply to the meniscus comes in from the outside portion, from the periphery of the knee, and then it sort of peters out as you get inside the knee to the thinner, wispier portions of the meniscus. This really is more important as it relates to healability of meniscus tears and sometimes treatment as far as what we do surgically to take care of these issues. Tears that tend to be in the outer red zone, it's red because of the blood supply, have a better chance of healing with appropriate treatment, with appropriate bracing and protection. The blood supply, as we see a lot in sports medicine and soft tissue injuries, is really crucial for the healing process. As we get further to the inside portion of the knee, not only does that meniscus get much thinner, but it gets to the point where there really isn't any blood supply. So those are the areas where we typically hear about people that didn't have their meniscus repaired, they had it resected. It tends to be because of tears in that region. This diagram here kind of shows you different types of tears, and not all meniscus tear, not every meniscus tear is the same. So there can certainly be different types of tears. A lot of times we'll get these little free edge tears, these thinner tears, and I likened it to a pair of shredded, stylish probably know are very expensive jeans, but back when I was growing up, those were the types of jeans you would put patches on. The reality is, as that tissue breaks down just in response to life and it starts to fray, you can sometimes catch this tissue to cause bigger tears. Sometimes we'll see this with deep squatting. I'll hear people say, well, I was out working in my garden. I was sort of down in a squatting position for 30 minutes, 45 minutes. When you're bent knee position, you're putting a lot of load on that meniscus. And then as you're twisting and turning, that can start to shear the meniscus apart. Sometimes with twisting and turning injuries, it could be golf, it could be turning to throw a ball, it could be slipping on the ice. That kind of twisting also puts a lot of load through the meniscus. A common test that we'll do in the office, we call it the duck walk. And this is something I'll do on all my sports physicals for athletes looking for clearance for participation. But if you can squat down like this, you can see the gentleman demonstrating this in this example. That knee is almost to 90 degrees. So as you bend down, load on that meniscus and just that waddling back and forth. And I always, when I have my patients do say that quacking is optional, but when you're down into the bent position, you're putting a lot of load on that meniscus. If you have a locked knee, is locking, it gets caught. When I go to get up from a table, I feel like I can't walk on it. I can't do what I need to do. That can be a symptom of a meniscus tear. Certainly, and here's a picture just to show you what it looks like on an MRI image. So the meniscus, if we look closely, really on this image should be this dark black triangle. Sometimes we talk about a bow tie where you've got a portion in the front of the knee and a portion in the back, but this demonstrates what a tear looks like, where you've got this white line where there's fluid running within the meniscus itself, extending to one of the surfaces. If you see that in MRI, that's pretty classic for a tear. What do we do about it, right? Sometimes meniscus tears become symptomatic, sometimes they become less symptomatic or asymptomatic. So it really kind of depends on how, and I use this line a lot, it really comes down to how does it function, how does it feel? If a meniscus tear calms down and you're able to get back to your full activity, great. The right answer is do nothing. If the knee is locking or giving way, or if you simply find, man, every time I get out of the car, try to twist or turn, I just get this sharp stabbing pain. That's the type of case where sometimes we can go in arthroscopically to remove a flap. Here's some pictures sort of arthroscopy in the bottom here, showing what a little flap tear of the meniscus looks like. And you can see this is in that thin wispy area of the meniscus, the area we talked about where there's really not much blood supply, what we would refer to as the white zone. And these are areas that respond well to going in there with a little biter, just kind of nibble up that tiny little flap tear. The overall principle in meniscus surgery is definitely preservation. We want to keep and retain as much of that meniscus that's there that acts as a natural shock absorber as long as possible, because it's protecting the cartilage in the knee and it's actually protecting against further wear and tear and arthritis. My little picture in the bottom right kind of shows a long, windy road. And I like to use the analogy that sometimes when the meniscus tears, this is sort of the first step in a longer journey, right? As the knee starts to break down and wear out in response to life, the meniscus starts to degenerate, starts to tear. That in turn puts more load on the cartilage coating on the bone. It's like the treads and the tires on your car. Now, as the treads on the tires start to thin out and wear out, it puts more pressure back on the meniscus, and you kind of go down this longer road of wear and tear. So I think a common misconception sometimes is that, oh, I had a meniscus tear on my knee. They went in and trimmed it out, and now my knee should be fine. And the reality is we recognize that it's a much longer journey. From that, I'll go in to talk about some ligament injuries. One of the most common ligament injuries that you hear about and read about are ACL injuries. The ACL is a stabilizing ligament in the knee, and its really main function is both stability, both front to back, but more importantly, rotational control. So the diagrams here kind of show the ACL is the ligament that's sort of running obliquely in the front part of the knee. There's an arthroscopic picture here in the middle showing what it looks like at the time of surgery. This nice, thick, shiny, white ligament. And, again, you oftentimes hear about ACL injuries in sports, right? So-and-so twisting injury, felt the pop, had pain, had rapid swelling, didn't feel comfortable, didn't have confidence in it, can't go back to play. And that's consistent with an ACL injury. In fact, if I hear that story, there was a twist, a pop, it felt unstable, it swelled up rapidly. It's in my mind, I'm thinking the David Letterman top 10 list is ACL, 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 ACL. It's a very consistent history and a very common history for ACL type injuries. Initially, for ACL injuries, like a lot of these knee injuries, the common theme here is rice, right? Some ice, a lot of times putting the knee in an immobilizer to at least give it some stability, some support, so it doesn't just give out on you. Sometimes crutches can be beneficial to unload that joint, take some pressure off. And then the diagram here at the right, unfortunately, most of the time, and there's some exceptions, but most of the time when your ACL tears, if you wish to return to a functional lifestyle, and it doesn't have to be Division I football, the ACL is important. So most of the time, the recommendation is for surgery to put a new ACL back in the knee to provide stability back to that knee. Not only as it protects rotation and motion, it also protects the meniscus and the cartilage. So you can imagine that if your knee is now sliding around a lot more than what it was prior to an ACL injury, it's almost like taking sandpaper to the cartilage. It does lead to more accelerated wear and tear. And we know that the natural progression over time for ACL injuries, especially that are untreated, is significant arthritis down the road. The MCL is another common injury in the knee. The MCL is to some extent less important, certainly from a surgical standpoint. The MCL, or the medial collateral ligament, is a ligament that runs down the inside portion of your knee. This is something that we'll see getting injured when athletes get hit from the outside. So it's common in soccer, trying to make a slide tackle, going for the ball. We see a lot in football with tackling, especially linemen, even your own linemen rolling up on you when you're down there in the box trying to keep people out. And that's why a lot of times we'll see, especially collegiate and professional linemen, wearing hinged knee braces. The braces are there to stabilize the knee from side to side to help protect the MCL. There was some good work done at West Point a long time ago that really looked at MCL injuries, and they found a significant improvement and reduction in injuries with those hinged knee braces. How does an MCL injury present? A lot of times you'll, again, complain about pain on the inside of the knee. A lot of times people will come in and say, I just can't bend it, especially the next day. So if you get hit on the outside, it may be a little sore, may feel a little stiff. It's not until you wake up the next morning that a lot of times it'll be really hard to bend. You won't want to bend it. You won't want to straighten it all the way. And that's because as you do bend and extend the knee, the MCL actually has different portions that are under tension. So at different degrees of knee bend, different portions of the MCL are tight and others are lax. And so early on, that's a very common theme. Sometimes you get some bruising. You may get a little bit of swelling. It shouldn't be this rapid, profuse swelling that we'll see with an ACL injury, for example. And a lot of times patients will say, it just feels loose. When I put weight on it, especially trying to take your shoes off, close the door, move kids' toys on the floor, they'll say, yeah, it's really uncomfortable on the inside part of my knee. Again, common theme, right? Ice, bracing, crutches to unload. Most of the time, the nice thing about MCL injuries or MCL sprains is that they get better on their own. If you give them an opportunity, if you change activity, if you protect that ligament, it does get better. This can sometimes take the better part of 6 weeks, which for in-season athletes is not really the news they want to hear. But again, most of the time, this is not a surgical problem, which is good. When we talk about the patellofemoral joint now, we're talking about the kneecap and sort of its interaction to the front part of the knee. And so the patella, the kneecap, sort of floats and rests on the cartilage on the front inside part of the knee. You've got your quadriceps tendon and muscle pulling upward on that kneecap, and you've got the patellar ligament holding things to the bone below. And so you can see on the diagram here, just as you bend and extend your knee, how that kneecap moves up and down. The patellofemoral joint is very important for generating power. So for jumping, and we'll see problems with the patellofemoral joint as it relates to jumping athletes. But we'll also see it in people that have a more sedentary lifestyle. So I think that the next few things we're going to discuss are really all related to the patellofemoral joint. So keep some of these mechanics in mind. When we talk about general symptoms of a patellofemoral injury, you may get some visible bruising or swelling, especially if you land right on that knee. A lot of times for some of these injuries, people say, man, I can't straighten my leg. Like somebody can straighten it for me. I'm just unable to actively straighten that leg on my own. And common, like the far on the right here, they say, I don't trust it. It won't hold me up. I feel like it gives out, especially going downstairs, going upstairs, some kind of incline or decline. When we talk about tendon ruptures, so around the knee, we're talking about the quadriceps tendon, which is the diagram here on the upper right, where the tendon tears right off of the kneecap, or the patellar tendon or ligament where it tears just below the kneecap. Again, both of these injuries cause loss of being able to extend the leg, bruising, swelling, weakness, and the knee feeling unstable. The video playing on the upper left there is just a picture, and I was showing how he's running to first base to try to get the out. And as he tries to stop quickly, he gets what's called an eccentric contraction. He loads his quadriceps to try to slow him down, and it's just enough force that it actually pops the patellar tendon. I recently took care of a power lifter that was in the sort of in the circuit for the strongman, and he's a professional athlete, and he tore his patellar tendon. I think he was pulling a trolley, like you'll see sometimes on ESPN where they put the rope over their shoulder and they're trying to pull the trolley in the street. So extreme loads can cause ruptures of the tendons. Sometimes you get falls on the stairs that can cause the tendons, and sometimes it's not the fall that caused the tendon tear. The tendon tears and it led to a fall on the stairs. So that's always an important piece of history to try to tease out. But when this happens, it's not subtle. It's sort of like a bomb going off. I mean, usually patients say, man, I felt something pop, and it just was, I fell down. I had no strength in my leg. Different causes for tendon ruptures. We do know that there are certain antibiotics out there that can lead to tendon ruptures and tendon weakening. So this is always part of the history that we like to ask, were you recently on antibiotics for a respiratory infection, for a urinary tract infection? So there are different medications out there that are known to put you at risk for tendon injuries. Cortisone injections, and really not cortisone per se in the knee, but cortisone into or around a tendon. And so most of us in sports medicine, one of the big things that we talk about is not putting cortisone in or around tendons. This goes for the Achilles tendon in the back of the foot, quadriceps tendon, patellar tendon, arms, shoulders. I mean, there can be risks to cortisone injections. Connective tissue diseases. We know a lot of the rheumatologic or inflammatory diseases out there do affect our connective tissues. And again, thinking back to that slide earlier in the talk tonight about collagen and what collagen is and how collagen makes up tendons and ligaments and your tissues in your body, certainly disorders of collagen and connective tissue is a big risk factor. Age. As we age, the blood supply gets worse. It gets less to our tendons and ligaments. The ability to remodel and heal goes down. The tendons just get weaker. Smoking is a big cause. Nicotine, as it affects the blood supply and causes the vessels to constrict, sort of cutting off the blood supply to the tendons and ligaments, that can be a huge risk factor for tendon ruptures and tendon injuries. And we certainly know that packing a few extra pounds, extra load, extra weight on a joint certainly puts more stress on that joint and certainly can be implicated as well. Patella fracture, so breaking the kneecap, you can tear the tendon, but you can also break the bone. We'll see this sometimes, and I had a young lady this morning that was in a motor vehicle accident 2 weeks ago, and her knee hit the dashboard, and sometimes a quick sudden blow on a dashboard, certainly in sports, falling on the knee, falling on the sidewalk, falling on the snow and ice, or sometimes even a direct blow, hitting it on a helmet. Enough force and that bone can split. In general, there are different types of kneecap or patella fractures. Some require surgery. Fortunately, a lot do not. If you have a break like this, where there's a break that splits sort of up and down, thinking about your quadriceps and patellar tendon, those two tendons are working against each other, right? They're sort of pulling on that bone in opposite directions. So if you have a fracture that runs in line of that pull, those muscles, those tendons pulling are not going to cause this to displace, or not going to cause this to get to the point where it needs to have something done surgically. Sometimes you'll get lucky too. You will get a fracture that runs more horizontal, what we call transverse, where you worry in this case, could those pieces come apart if you keep trying to do too much on it? And these are the cases where we'll want to put you in a brace and sort of watch you closely with serial x-rays every week or two, just to make sure that things aren't falling apart. But like this x-ray shows, you can see from the side, where the break is, but you can still see that those two pieces are together, right? Those two halves are still whole. It's not until you get something like this picture up here, where you can see now two distinct pieces. There is displacement. And a lot of times on exam, you'll actually be able to put your finger, you'll be able to feel that defect as the two halves have pulled apart. So in those cases, surgery is required to go in to kind of bring those two halves back together and to hold things back together so things can heal appropriately. Finally, we can talk about patellar dislocation. So the kneecap popping out. And it can go through different series where sometimes the kneecap sort of slides off to the side and then pops back in. And other times it actually pops out and it stays out. And a lot of times it's from similar to an MCL injury, getting hit on the outside of that knee where that knee bends inward, but also a little bit of a rotational component to it. In general, when you have a kneecap dislocation, we do not recommend this strategy of just trying to knock it back into place. Oftentimes, you definitely want to try to be a little bit more cautious to help get it to go back into place because, and I'll show you in a slide here in a minute, we can sometimes see cartilage damage. In my hands, most of us, if you have a kneecap dislocation, a lot of times the initial treatment is actually getting an MRI. The initial treatment is bracing, ice, protecting it, but we want to get an MRI to take a closer look to see, has there been any damage to the cartilage underneath the kneecap? The act of it popping out and then coming back in, did that do anything mechanically to the knee? For those of you that don't know, I always like to take an opportunity, public service announcement. MRIs, they're not radiation. It works as a magnet vibrating water molecules. And the higher the water content in a tissue in the knee or in the body, the brighter the signal. So as you might expect, blood has a lot of water in it. So on an MRI, blood is going to show up really bright. Tissues like cartilage, like bone, typically have less water, and they show up darker. And so MRIs are a very safe modality. There is no radiation. This diagram, again, kind of shows diagrammatically what happens when your kneecap pops out. So it slides off the side and then it hits. And sometimes, and this was an athlete of mine about a year ago, when he dislocated his kneecap, it actually sheared off the cartilage. It knocked off that protective cartilage coating underneath the bone. So this yellow area here in the middle is actually bare bone. The white surrounding that is nice, healthy cartilage. As you might imagine, that doesn't do very well if left alone. This is something that you want to treat. And so fortunately, I was able to go in there, take that piece that was floating around the knee, put it back into that pothole, if you will. And then we have some little dissolvable screws to help hold it in place. And he's back to running and jumping and doesn't have any problems at all. So it can be a very effective treatment. But this is why it's important to come in to be seen after this type of an injury, as well as to get an MRI to look for this kind of a problem. Because if you don't look, you won't know, and you don't want to find out years down the road, because that cartilage piece, when it falls off, it doesn't stay nice and whole and viable for very long. If there's no blood supply to that cartilage, eventually the cells in that piece die and it's not salvageable. So again, for patellar dislocation, like a lot of these common theme, ice, brace, protected weight bearing with crutches, and really physical therapy. Most of the time, unless you see an instance like that where the cartilage gets knocked off, most of the time, patellar dislocations are treated with bracing, physical therapy, and a return to function very successfully with non-surgical management. Having said that, there are cases where if the kneecap continues to be unstable and pop in or out, there are ways that we can go in there to restore stability. And the picture on the left kind of shows an example of a common ligament surgery where we try to, it's almost like putting horse reins on a horse, right? We kind of make this check rein on the inside of the knee so the kneecap can't slide off to the side. And sometimes just the way the body formed and the bones formed, there's actually underlying mechanical malalignment that involves the need to have to cut that bony insertion, the patellar tendon where it attaches to the bone down here. Sometimes we actually have to cut that attachment point and move it over a little bit and then put some screws back in it to get it to heal. And that can be a very effective strategy as well. All right, the last part of the talk here before we get to questions, I think I'm right on time. Injury prevention, right? So great. We learned a lot about different injuries around the knee. Is there anything we can do to prevent this from happening to us? In general, I think the idea of warming up and stretching is important. And just stretching in general is a very effective modality just to kind of keep your joints healthy, keep your muscles and tendons healthy. So, but especially before you're going to do anything rigorous, I don't care if it's yard work or going for a jog, it's good to take a few minutes to stretch and warm up. Listen to your body. Most of you are going to know when something starts to feel off, if something doesn't feel right. And don't just put your head in the sand and keep pushing. Get to know your body, get to recognize when something feels different, when something feels off. And the biggest thing is don't run the engine in the red, right? Don't push your luck. Don't keep going. Well, maybe it'll get better if I run another mile. Maybe it'll get better if I run another 5 miles or whatever it is. Listen to your body. Be careful, because if you keep pushing too long, that's when bad things can happen. Again, don't ignore pain. Appreciate the message. Take that feedback. Say, okay, thank you for the warning. I hear you, but don't ignore it. Don't just push through it. A lot of times, first line treatment, again, anti-inflammatories and ice. I'm not saying it's going to be completely curative, but it's a good starting point to help put that fire out, or at least calm things down. And be patient. Sometimes these things can take time. And sometimes, I'll tell patients, hey, you may need to take anti-inflammatories and ice for the next couple of weeks. And I will talk a lot about being proactive versus reactive, meaning don't wait until the body part, till the knee is so painful that you have to take something. Take something ahead of time. Take an anti-inflammatory like Aleve, Motrin, ibuprofen to enable you, to help you in doing those activities, as well as icing. So it can take some time. All right, with that, I just want to pull up the last slide again. I'm again located at the Schoolcraft campus in Livonia, right off of 275 and 7 Mile. Our orthopedic hotline, if you will, is 866-ORTHO-IHA or 678-4644. And if you call that direct extension and say, hey, I'm having shoulder pain, I'm having knee pain, I'm having some hip pain, I'd like to get in to see Dr. Aalderink. He seemed like he had some idea what he was talking about. I'd be happy to see you. I appreciate your attention tonight. And I think that gives us about 15 minutes or so to go through questions. The only thing I don't like about Zoom presentations is I like to kind of engage and interact with the audience. So I know I'm getting here to talk to myself a lot. The hard thing is knowing if any of my jokes landed or not. So I don't think there was anything too controversial, but I apologize if there were some bad jokes. Definitely give some feedback and I'll change that up for the next time I give a presentation.
Did you say bad jokes or dad jokes? You may be guilty of some
potentially
bad
both.
Jokes.
I've been known to do both, but bad with a B.
Oh, got it.
Dad would be acceptable, I suppose, as I am. But yeah.
All right. Well, that was an amazing presentation. I think I might have TMJ from cringing at some of those injuries. But yeah, that was incredible. All right.
Okay.
So it looks like we have over 20 questions already. So please enter your questions as you think of them. I'm going to start off with this one. It's the best diagnostic test for knee issues. So would that be X-ray, ultrasound, or MRI? Sounds like multiple choice.
Well, yeah, honestly, I think the best example, the best test is just a good physical exam, because you can get a lot on physical exam, moving the knee around. I can get a lot of information on how your knee feels, how it moves, instability, weakness. So that's always the best first line. It's pretty routine to start simple. So starting with x-rays, you can actually get a lot of information from x-rays. We're not just looking for a break in the bone or a fracture. Certainly not just looking for arthritis. You can get a lot of subtle information that's not so subtle for a sports medicine doctor starting out with an x-ray. From there, it kind of depends on what the physical exam is sort of leading you toward. If there's gross instability of the knee and I'm concerned about a ligament injury, then oftentimes I'll get an MRI. If it's discomfort that might be tendonitis, bursitis, and even a meniscus, for the most part, I tend to be pretty conservative. We talk about maybe some physical therapy, again, ice, anti-inflammatories, and patience, just giving it some time to kind of see how things are going to play out. But I do think, there's certainly a role for those different options. In general, ultrasound, it's not a high yield test. It certainly has a place for people that can't get MRIs if they need one. But in general, I don't order many, if at all, ultrasounds in my practice, just because I get much more information from an MRI.
Okay. You are getting people in the Q&A saying they did enjoy your jokes, so you can
Thank you.
rest assured.
They can't throw tomatoes at me over Zoom, so I guess I'm safe, but that's good feedback. Thank you.
This is true. Okay. After meniscus surgery, is it normal for the knee to feel some instability, and should this resolve over time?
Yeah, I think early on, a lot of times after surgery, the knee is going to feel unstable just because you've gone in there, you've created more irritation, if you will, you get swelling. And so when there's fluid on the knee, there's going to be inherently some instability. I think that's a complex question, and whoever asked it probably doesn't even know how complex that question really is, because it kind of depends on what the meniscus surgery was, right? So again, was it something where we resected meniscus, we took off a tiny little flap, or did we repair the meniscus? Did we sew it back together to try to get it to heal? Was it a small piece? Was it a big piece? So, I mean, there's a lot that can lend itself to, persistent problems. But in general, if it was a knee scope or a simple knee scope where you had a portion of the meniscus removed, in general, 4 to 6 weeks afterward, you should be in pretty good shape. If there's still some laxity, some looseness, that's where sometimes a knee brace, a compressive sleeve therapy can be advantageous. But I definitely would get back in to see, your provider, whether or not it was your primary care doctor or an orthopedic surgeon or a sports medicine specialist, if you're finding that it doesn't seem like it's getting better. Again, I wouldn't ignore that.
Okay. There are a few questions on your anti-inflammatories. So you did mention a couple that you thought, or you mentioned a couple names. So Aleve, ibuprofen.
Yep. Aleve is good. It's a
Okay.
longer acting medication. So it's something that you typically can get away with taking twice a day, kind of morning and night kind of thing, and you can get big bottles at Costco or Sam's. The Motrins and ibuprofens are more short acting, a little bit more punch, but you just have to take it more regularly. And really, I should say, for any anti-inflammatories, you want to be cautious because you certainly can overtake anti-inflammatories. If you have any sort of reflux or heartburn where you're taking them, that's something that you want to be cautious with and make sure you have that discussion with the provider. If you had a history of ulcers, you want to have a discussion. If you have bad kidney disease, you want to make sure you're having a discussion. Most of the time, extremely effective and extremely safe medications, even taken for long periods of time. But again, there are circumstances where you want to exercise some caution and restraint.
That was a perfect segue, because the next question was about that. How long can you safely take an anti-inflammatory? So how often can you take it? Is it, if you're someone who is exercising daily, is it safe to do that every single day, or is that something you need to look for an alternative?
Yeah, no, I would say it can be, and the easy answer is it depends, right? I mean, I've got college and professional athletes that take somewhere upwards of 24 to 3,200 milligrams of ibuprofen every single day for the better part of 9 months a year. So, they're breaking their bodies down, they're beating them up. When I was at University of Iowa, they call them greenies because the ibuprofen pills were green gel tabs, and doc, I need some greenies. So again, it can be safe and effective. It kind of just depends, about other factors. You're a younger athlete. Are you a middle-aged athlete? Are you an older athlete? What else are you doing? I think in isolation, just taking the anti-inflammatory is not going to be a good recipe for success, but in a bigger context of modifying activities, icing, bracing, it can be very effective and very safe, again, taken for long periods of time. And oftentimes I'll talk to patients about taking them as a way to help you do things so you can go out there and go for that walk. So you can go out there and go for that jog. Because the problem is, if you can't start to rebuild strength and function, the inflammation persists because of weakness and stiffness. And so it's sort of the hamster in the wheel effect. You got to start somewhere to kind of get moving in the right direction. And again, that's part of the coaching, right? That's part of the discussion that we have together in the office when I'm there with you to help figure out what that best plan is for you.
So it sounds like the best thing to do is to talk to your own provider and they will help you find what's right for you specifically in your body. So before you head to Costco, head to the provider.
Yeah, I mean, especially if it's something that's been, either an acute injury where you have some of those signs, that pop, that rapid swelling, that intense pain. And I would expect most people probably are intuitively going to seek evaluation at that point. But even for a more chronic injury, something you're like, man, this just doesn't seem to be going away, and my quality of life is functioning, how it feels and how it functions is taking a hit. Don't feel like you have to just live with it. At least, I'm happy to see you. I'm happy to have that discussion to try to figure out different strategies to get you back to where you want to be.
Okay, cool. All right. The next person is a 75-year-old woman. She has a torn meniscus. And then she kind of breaks down. Her first choice would be physical therapy. If that doesn't help, then injection. And if that doesn't work, how about surgery? Does that seem like a reasonable or hopeful recovery path?
I like that starting point. I like that progression. In general, I wholeheartedly agree with that. As far as surgery goes, and we didn't really talk about this much tonight because it was more talking about acute injuries, but it really comes down to how much arthritis is there, right? So arthritis as a definition, arthritis really has to do with the cartilage coating on the ends of the bones, much like the treads on the tires on your car. Over life, just in response to daily activity, right, driving the car, the treads on the tires, that cartilage coating thins out and wears out. As it thins out, that space collapses down. It puts more pressure on the meniscus. And so you can see meniscus tears kind of going hand in hand with arthritis. Meniscus tears do well with surgery if there's not much arthritis. If you have even moderate arthritis, moderate collapsing down, cartilage thinning, the results with meniscus surgery, I oftentimes joke with my patients. I say going in to do surgery on this meniscus would be good for two things, and that's both my boys' college funds, but probably wouldn't affect you very much. And so the wrong answer, in my opinion, and most of us within the sports medicine world recognize that surgery for a degenerative meniscus tear in the face of osteoarthritis, the results aren't great. So going back to the injection, I think that's a much better option. That can be a lengthy discussion as well, because there are different injections, right? You've got your steroids as one option, and you've got the gel injections. All the data coming out, evidence-based medicine, it's growing, is telling us just how bad steroids can be. Cortisone kills cartilage. Putting steroids in your knee repeatedly as a preservation mode can actually lead to more wear and tear over time. It's like robbing Peter to pay Paul. So you're creating a bigger problem over time. They also affect blood sugars in diabetics and immune response. So I think a lot of the data now is starting to point toward the gel injections as being a more biologic, safer alternative. The gel injections are made of hyaluronic acid. You'll see commercials on TV talking about facial creams and lotions for wrinkles. This is a good way to get rid of those wrinkles inside your knee that you don't know about. But the reality is the gel injections help to lubricate the joint and calm down inflammation. And it can be a much safer long-term strategy. And I've got patients I've been treating for over 10 years that come in sometimes once a year to get, it's almost like an oil change, get the gel injections in their knees, and it keeps them going. When you decide to do something like a knee replacement for arthritis, for example, my opinion is that's the end of the road, right? That's a quality of life decision that you make when you say, look, I've exhausted everything else. I am exhausted. I've tried everything else. It's not giving me the quality of life I expect and want. That's when you put new tires on the car. That's when you get a knee replacement. Sorry, I got off topic, but that's my soapbox, their discussion.
It works. When you're comment about a steroid injection, is that true for oral steroids as well? Do they damage cartilage?
No, great question. That's different, right? So if you're putting steroids right into the joint and you're bathing the cartilage cells in cartilage in a joint with cortisone or with a steroid, that's when we know there can be some deleterious effects. Oral steroids don't get into the joint itself. It's more in the bloodstream, and they're good at targeting inflammation, but they're not going right into the joint, so the cartilage is safe.
Gotcha. Okay, the next person was diagnosed with a Baker cyst in December, and she's still having issues and trouble walking. So a couple of questions here. How long should this healing process be? And is it time to maybe ask her primary care physician for an ortho referral?
Yeah, that's a great question. I get that a lot. I mean, and that sometimes is the first thing that you see. So just for everybody to be aware, so a Baker's cyst is basically a fluid collection behind the knee. So inflammation happens. Inflammation can come from meniscus tears, from arthritis, just from overuse and activity. Inflammation is the spark that sets the flame. So that leads to fluid production on the knee. As the knee swells, as you walk around and bend it, that fluid starts to leak out behind the knee and collect into a pocket. So a lot of times people will say, yeah, that tightness behind my knee, that bump that I feel gets harder, more firm after activity. But if I elevate it in ice and take it easy, it seems to sort of calm down and get a little bit softer. The bigger question here is what the driver of the Baker's cyst is. The Baker's cyst is never the primary problem. It's just a normal reaction from your body. The bigger question is, how do I stop the inflammation? How do we turn off that tap so that as the water in the knee is trying to fill up, we can slow that down so that the body can resorb the fluid, it can go away. And sometimes, again, anti-inflammatories can help. Sometimes the gel injections can be very effective at that as well. The one thing that I discourage and recommend against, which really isn't mainstream anymore, is putting a needle into it. Sometimes people come in, they're like, well, can you drain it? Can you take that fluid off? Yeah, you can. But again, the reality is most of the time, unless you fix the primary problem, the fluid comes right back, much like the bursitis that we talked about earlier. So typically, we don't recommend putting needles into these. Not only is it uncomfortable, it can also be a risk of infection, as well as in the back of the knee, there's a lot of very important structures that you don't want a needle to hit. So it's not something we generally recommend or do.
Okay. Can you get a Baker's cyst on other joints? It feels like I've heard of them on a wrist, maybe.
Yeah, you can get cysts. So ganglion cysts are common. You see around the wrist. They have a different name. The Baker's cyst is really more specific to the knee, just that terminology, but you can get fluid collections from any joints. And typically, as the joint breaks down and wears out, you'll get inflammation, and that cyst can form. We see them around toes. We see them around the wrist. Sometimes we see them around the shoulder, the elbow. So yeah, you can pretty much get it anywhere there's a joint.
Okay. This person is asking, what is the oldest age person on which you would repair an ACL?
Honestly, it's more about the physiological age, or activity level, rather, not so much the biological age. So, I mean, I've certainly repaired and reconstructed ACLs in patients in their late 50s because they're active, right? They enjoy downhill skiing. They enjoy doing things that involve twisting and turning. Sometimes even with golf, I mean, Tiger Woods eventually got his ACL reconstructed because, it affected his golf game. So I don't want to draw a line in the sand. I think overall, it just kind of depends on the individual. It depends on what you've tried, right? The more aged athlete, if they feel comfortable with a brace and they do some physical therapy and their knee doesn't give them any trouble, I think that's a reasonable option. So it just, again, I hate to keep saying it depends, but it kind of depends on the situation.
Yeah, I think, like you said, I think having those conversations with your doctor about your personal case is probably the best next step, right?
Like, what are you trying to, what do you want to achieve? What is your desired activity level? What types of things specifically do you want to do? Are you willing to give up pickleball, or do you want to really focus on that? Cornhole doesn't involve a lot of twisting and turning.
That's true. It sounds like a pretty safe sport for your knee, although you do have to bend to pick up the bags. So, I mean,
that's fair. And somebody has to carry the big boards back into the house. And that
yeah, exactly. I don't know. That might be more dangerous than we realize. So if you do get, or if you are injured, you talked about putting ice on for that 15-minute time frame. Is heat ever a better option, or should it ever be used in conjunction with ice?
Yeah, that's a great question. I personally like heat. I don't think there really is a right or wrong, to be honest with you. Early on with acute injuries, ice, because it targets inflammation and swelling, tends to be a little bit more effective. But certainly as injuries go on, or if you start saying, well, I've been having problems for a while, heat helps to relax muscles. It can help with blood flow. And so we know that both hot and cold can both be effective measures for treating inflammation. I tell my patients, figure out what works best for you, right? Because just because it works better for somebody else doesn't mean that's going to be the same for you. So I think, there's value in trying both.
All right. And is there anything you can do to strengthen your knees using weights, or maybe addressing the muscles around the knee? What can you
Yeah,
do?
that's extremely important. And I would say a lot of the, if not all of the things we discussed tonight, at some point, the strength and conditioning is extremely important. It can be very beneficial in prevention of injury. So doing some simple standing squats, right? Just standing with your feet shoulder width apart in your living room, your kitchen, bending down to bend your knees about 90 degrees, just body weight squats. Sometimes we talk about wall sits, where you just sort of sit against the wall and hold that position. Or some people will use like a ball where they'll kind of roll up and down with the ball between their back and the wall, just to help get some strength back in the legs. But strengthening, especially as we age, becomes an extremely important part of both preservation of function and injury prevention. And that's where physical therapy can be very beneficial, right? That's where our partners, both at Trinity Health, Elite Sport, even in our office, Probility is right there. They can really help to design a good home program for you, to show you different exercises that can be accomplished. And again, most of it is something that can be accomplished at home. So for physical therapy, sometimes it's going for a couple of visits to learn what to do and how to do it. Then the real challenge is, staying motivated and staying disciplined to continue doing it.
So it takes a village to fix a knee, it sounds like.
It takes a village to fix all of us. Not just the knee. That's right.
Right. That's why there are so many services available in one building there on Schoolcraft.
Exactly. Yep. That's our plan, is to keep it convenient for all of you.
Yes. And we are just a couple minutes after 8 p.m. Are you okay to stay on for a few more questions?
Sure. I see that the questions are growing and not
they are rolling in. Yes. Yes. They're rolling in. This one sounds futuristic. So I hear other treatments like stem cell injection taken from bone marrow to help grow cartilage on the knee.
Yeah, I get that question a lot. I will tell you, I will answer that question as two parts. One, the current evidence-based medicine that we have does not support good outcomes using stem cells. We don't have the ability yet to get these cells to do just that, to grow cartilage, to grow whatever it is we're trying to grow. We don't have a way to control that. So there's, trust me, millions of dollars of research looking at this. And I do think that at some point there may be opportunity that becomes available. But unfortunately right now, and I know there are people not even far from here that do, charge patients and accept cash payments for this procedure, largely as a board certified surgeon who also teaches and attends our academy conferences and lectures. I will tell you that currently the evidence is lacking. You may find your anecdotal, this helped this person or help that person, but by and large, I will tell you, I've seen hundreds of patients that have paid that money out of pocket and been very disappointed, as it did not lead to any improvement whatsoever. So I would be cautious with that. I would not recommend proceeding down that path without at least having a more in-depth discussion with, myself or another provider.
Okay. I am going to admit that our audience is much smarter than I am, so I'm probably going to trip over some of the terminology in this. I work in marketing. Yeah, we do the parties and all the fun stuff. All right. So this person did PT for a patellofemoral pain syndrome, and they noted poor patellar tracking. Is that a lifelong situation, or can they continue to do PT?
Yeah, I mean, PT is certainly part of it. So strengthening the muscles around the knee can help with patellar tracking. Most of the time, the patella, when it doesn't move up and down in the middle of that groove, we talk about the car sort of driving up on the curb. Some of that, really doesn't involve just strengthening the leg muscles as somebody might expect, but a lot of it's core strength, hip muscle strength as well. A lot of it can be related, again, to the foot and ankle. So people that have feet where their arches have collapsed down, you'll be surprised how just getting some off-the-shelf, not custom, but off-the-shelf orthotics can make a huge difference, as it helps to correct some malalignment in the leg, which then helps in turn with that kneecap tracking more centrally in the middle of that road. But certainly, if there's a lot of maltracking that's leading to instability episodes where it's popping out or just persistent pain, I mean, there are ways that can be treated by changing that mechanical alignment. That one slide I showed, let's see if I can find it here, right down here, where we talk about cutting the bone and sliding things over. By sliding that bony attachment over, you're actually pulling that kneecap back over into the center of the groove. So this is a great example sometimes where patellar maltracking, if it still remains symptomatic, can be successfully treated surgically to fix that malalignment. But therapy is a big part of it.
Okay. There are a lot of people who are talking about their knee injuries. I'm trying to find the common themes and ask those, because I know you probably won't.
It's a common problem, right?
Yes.
We could probably talk about this all night. Maybe by that time the snow will be melted, but
So there are definitely 75 questions. So we probably won't get to all of them. I will do my best to try to get those common themes though. So it looks like we have a couple fall injuries. This person is saying they fell twice, 2 years apart. Their knee is still swollen and numb through PT. Is that something she should stop back into the orthopedic surgeon?
Yeah, I mean, if it hasn't been formally evaluated with, at least with x-rays, but it's certainly with a specialist, I think, for something that's lasted that long, it's definitely worth taking a closer look. The numbness, sometimes there's a nerve that sort of passes over the front part of the knee. And if you smack it hard enough, as with a fall, there are cases where sometimes that nerve just goes to sleep and it doesn't wake back up. So sometimes that can explain the numbness, but more often than not, it's not a nerve problem. It's just the swelling. It's the fluid on the knee that leads to that numbness. And so the bigger question in my mind is, why is it still swollen this far out? So you've tried therapy. I presume you've tried things like ice, anti-inflammatories, maybe compression sleep. Why is it still swollen? And MRIs can be useful sometimes to answer that question, depending on what the x-rays look like.
Okay. Have you ever heard of knock knees?
Yeah. So knock knee, all that really means is your knees bend inward, versus bow-legged John Wayne, where your knees bend out, right? So much like when the kneecap popped out, or those MCL injuries where you get hit on the outside and it forces the knee inward, sometimes people, just through development and growth, that's the way their knees form. And so that can cause a lot of problems with patellar tracking, because the more that your knee bends inward, your kneecap is just trying to stay in a straight line down the front of the knee. So the more that your knee deviates one way or another, it sort of creates this tug of war on the kneecap that can create maltracking problems. People that are bow-legged tend to have worse arthritis on the insides of their knee, or worse pain on the insides of the knee. Knock-kneed, or what we call valgus, is more pain on the outside. It has to do with just where you're putting more of that mechanical load when you walk around.
Okay, makes sense. This person is a runner, and she's wondering, is it enough to stretch for 10 minutes before running, or should she walk a short distance too to warm up?
Yeah, that's a great question. I know my wife always makes fun of me. She's like, you really should probably stretch and do a little bit more. I said, what? Bent over to tie my shoes. That's stretching, right? But no, I think in general, everybody's different. I think, the idea is just like a car engine on a cold day, right? You want to kind of get things loosened up and warm up. Injuries can happen when things are cold and stiff. So, whether or not it's 10 minutes may be more than enough for some people that do it regularly, that are very flexible, and they have a maintenance strategy, and other people that don't do it often, it may take a little bit more. So I think some form of warm up is always a good idea. Stretching, whether or not walking. I mean, I'll be honest, when I run, I don't really walk. I just say, let's get after this. But again, you got to listen to your body, right? And so if you find that it's better for you to give yourself that period to sort of warm up and get ready and move into the bigger workout, I think that's the right answer for you. I think you just got to listen to your body.
Okay. I'm not a runner, so I've been warming up for about 40 years now. Any minute now, I'm going to take off.
Never too late.
Can you talk about early degenerative changes in the knee? This one is, again, sorry for tripping, patellar malalignment issue. And is there something you can do to prevent it getting to be a more serious arthritis problem?
I joke around sometimes. People are like, well, what can I do to stop it? And I'm like, well, we're getting close. I guess you can move to the moon or maybe Mars. I mean, the reality is you can go someplace where there's less gravitational force that can help protect the cartilage. But no, the reality is a lot of what we've been talking about tonight, right? So the stronger that the joint is can really help the cartilage, being smart about what you're doing and how you're doing it, treating symptoms with ice, anti-inflammatories. At the end of the day, if you drive the car, the treads and the tires are going to wear out. It's no fun to keep the car parked in the garage all the time. Meaning if you're sedentary and you don't really use your body, yeah, you may say, okay, fine, the cartilage isn't going to break down, but that's not a good quality of life. And you develop other medical and health issues, right? So at the end of the day, our cartilage breaks down in our joints. It's an accepted thing that we know is going to happen. Having said that, I've got a lot of patients that are in their 70s that I've got one guy, he stands out. He's a top 10 in the world for his age group. He's in his mid 70s for marathon. He runs like 10 plus marathons a year. He came in about a year ago. I was like, my knee gets a little stiff and sore from time to time. I figured I'd just finally get it looked at. Got some x-rays. He's bone on bone. That means there is no cartilage left in that part of the knee. Yet here the guy is, it takes me being a leave once in a while, running marathons, and not just running them, but competing at a high level. And so the point is, it's not about what the x-ray show. It's not just about the amount of arthritis. It's really more about the bigger picture. It's about you, who you are, what else you're doing. And so, yes, cartilage can wear out. Yes, we develop arthritis, but it doesn't always mean loss of function and quality of life. I don't know if that answered the question.
I think so.
Okay.
Interesting. Okay. Can you talk about what happens when your knees lock up and what do you do to get out of that?
Yeah, it kind of depends. I mean, sometimes there's something called pseudo-locking, right? So if there's pain, the muscles around the knee just tense up, much like if you throw your back out and the muscles spasm and you kind of get that stiff, flat back. Same kind of thing can happen in the knee. So some of it can be, how do you get the muscles to relax? Heat can help with muscle relaxation. Massage can help, gentle stretching, ice, anti-inflammatories. If it's true locking, like something just, nope, I hit that gear and it's stuck and I have to jiggle it around, or man, I push here and something feels like it pops or slides out of the way. If it's true mechanical locking, that's something that you definitely should be seeing somebody for, because, if you have a loose piece of cartilage floating around or a flip of meniscus that's flopping around in there, I mean, that's something that can oftentimes be easily remedied with a simple arthroscopic surgery to prevent that from happening.
Okay. Is it common for meniscus clipping to result in a Baker cyst that constantly needs to be drained?
Yeah, so here we go, talking about the Baker, right? So I do not recommend draining Baker cysts. Your risk of infection goes up every time you put a needle in. My suspicion is the meniscus is the tip of the iceberg. I suspect that the meniscus clipping, or what we would call a resection, where we're removing a portion, it probably is not as innocent as that sounds. It probably is in the bigger picture of moderate arthritis in the knee, and it's more the arthritis that's leading to inflammation, fluid buildup, and the Baker cyst, and not really the meniscus itself.
Okay.
That would be my suspicion.
Well, and you are, I think, right on, because it sounds like they also have some joints offset as well and bone on bone there. So is there anything else that can be done for comfort, or is it time to see Dr. Pack?
Yeah, well, I mean, it just depends on if you are ready to put a new tire on the car, right? If you say, I've exhausted everything else, I've tried the gel injections, I take a low dose anti-inflammatory, I've tried everything else, it's not where I want to be. Unfortunately, in those situations, if you're bone on bone, you've exhausted everything else, I do think knee replacement can be a very successful option to restore quality of life and function. So, I get it, it's a big operation, and I certainly would want to exhaust other things first, but don't avoid it at the expense of cheating yourself out of quality of life, right? It's a very successful operation, and most, by and large, the majority of people get back to a very high functional level, and they're very happy they had it done.
Okay. So if you have something like osteoarthritis and you have an injury to your knee, whether it's an accident or fall or something in a sports injury, can that make the osteoarthritis worse, or kind of, I guess this person called it kicking it into high gear?
Right. Yeah. I talk about flaring it up, right? So you can have some baseline noise, some baseline inflammation, but if you have an injury that just sort of acutely pours more gas on that fire, yeah, you'll definitely, arthritis is really this whole roller coaster ride up and down. And it's trying to minimize the bad highs and try to, experience more of those more comfortable lows. And that's where a lot of times these other modalities anti-inflammatories, ice, physical therapy, strengthening, bracing can try to help. The gel injections I talk to patients about kind of make it more like a kiddie roller coaster, more it's a little bit less big highs and lows up and down that can try to help. But a lot of this is all, it's a bigger recipe to try to improve function and pain. And it's not going to work for every person, and it's not going to be 100% effective either. So a lot of times with time and patience in some of these modalities, you'll find that things do settle back down and go from that high gear back down to, lower RPMs where the engine's not running in the red so much.
Okay. What do you think of osteobiflex for knee pain?
There's a lot of supplements, a lot of topical creams, sprays out there. There's not great evidence-based medicine that says, one is better than the other. In general, I have patients that try them and they say, oh, icy hot feels better, or Bengay, or whatever it is. I mean, I don't have a problem with that. We do have some science that tells us, like a Voltaren gel. Voltaren, it's a topical anti-inflammatory gel that you can rub onto the knee. There is some science that actually shows that does have some benefit. So I guess you'd have to look at whatever the topical supplement is specifically to see what's in it. A lot of times these things are pretty innocent, so you can try them, but if you're not finding much improvement, I wouldn't necessarily continue to utilize those things.
And can you talk about the straps that we see athletes wearing above the knee to relieve pain? Does that work? And you recommend that for the everyday person? So I'm assuming they're talking about, like, go ahead.
No, I mean, it kind of depends on what the injury is and what you're treating, right? I mean, I see all too often some of my younger athletes that like to wear straps and braces and bands and stuff just because it looks cool, right? They see so-and-so wears it on TV and, oh, this guy in the NFL is wearing it, so sometimes they do it just because it's part of the overall, your overall just look. But there are a role for different braces. It just kind of depends on what you're treating, and I'm certainly happy to discuss those with you. We actually have somebody that's in our office with us from DonJoy that's right there to help provide braces and fit you for braces and ask and answer questions about braces and order braces. So we have that resource available when you're in the office with us that can help in those situations.
Cool. It's one-stop shopping. Okay. And what about if you develop flat foot? I'm trying to see, there are a couple questions on this. It looks like this person wears orthotics, but is there anything you can do to strengthen your arch or to get some of that arch back?
There is. I will largely punt this question to Dr. Neil Bakshi, our foot and ankle specialist, because that's really more in his lane of what he deals with on a day-to-day basis. But the answer is yes, there are different strategies. Now, sometimes those become surgical at some point, but I do think orthotics is a great starting point to help with a lot of those things. But yeah, I would encourage any of you, if you have a lot of questions about plantar fascia, foot and ankle issues, Dr. Bakshi is board certified and fellowship trained, and very, very bright and knowledgeable when it comes to everything foot and ankle, much more so than myself. He's a good partner to have.
Yeah, I would say so. How about the hip? Does an injury or a problem in the hip ever act like a knee injury or a knee pain?
Yeah, I think any joint injury is going to present with, stiffness, popping, catching, pain with certain positions. I mean, that's a common theme. The hip is particularly complex. There are more than 27 muscles and tendons that pass over and around the hip. And so one of my specialties and interests is more in the pre-arthritic or sports hip. And there are different things out there that lead to rubbing abnormally, something we call hip impingement, that can cause tears of different structures around the hip that can cause a lot of pain and problems. We'll see a lot of this in hockey players, hockey goalies, especially offensive, defensive linemen, catchers in baseball, anybody that spends a lot of time down in that squatting position that does cause pinching in the hip. And so there are a lot of strategies now that weren't present even 20 years ago to help repair things in the hip to prevent arthritis later in life. So maybe I'll have to come back for another Wednesday wellness webinar and talk more specifically about hip impingement. I'd be happy to do that.
Yeah.
But that's another whole hour discussion in and of itself.
Yes, definitely. These are complicated joints. So there are a lot of questions about popping, whether it's in the front in the kneecap or maybe on the side. A couple people have said,
Yeah.
Can you talk about what causes that pop? And it sounds like it's painful for some of these people.
And that's the thing to differentiate. Is it painful popping or is it just noise? And if it's just noise, I always jokingly say, just turn the music up louder. But the reality is those surfaces, as they're gliding over one another, if it's a nice smooth surface, like a smooth, freshly paved road, which I'm not sure they exist in Michigan, but if you find one, that can be a very noise-free ride, right? As the cartilage starts to break down, it's almost like getting little potholes in the road. So as things start gliding over cobblestone surfaces, that can create noise. Inflammation of the lining of the joint can cause popping and catching. So as the joint lining gets inflamed, you almost develop these little finger-like projections, these little sensitive areas that as now they get pinched and squeezed underneath the bone as it's bending and moving, that can cause popping. And sometimes tendons themselves, the tendon is tight, tendons can pop. Meniscus tears, if a little piece flips around in there, that can cause popping, loose pieces. So, I mean, there's a lot of different causes for knee popping. I usually try to separate it out as painful popping, non-painful popping. If it's painful popping, it probably should be looked at to make sure you're not missing an opportunity for something that's going to become a bigger problem down the road. And especially if it's popping with swelling too, right? If you're getting popping, you're like, man, my knee swells up. I get this popping, that's something to definitely get taken a look at.
Yeah, it doesn't hurt to pop in and see an orthopedic surgeon, right?
Correct.
Might
Again,
help.
most of what I do is not surgery, so don't be scared. I'm happy to help coach you through the right treatment strategies.
Excellent. Well, we've addressed a big number of these questions, and we appreciate you staying on for an extra 20 plus minutes. I enjoyed this immensely, and I'm going to go on a limb and say that I think our audience did too. And there are a lot of positive comments in here.
Thank you. It's my pleasure.
Yeah,
it's a lot of fun. I enjoy doing this for sure. So
you can tell. We can tell you enjoy doing this, and it sounds like you know what you're doing, which is always important.
I went to school for a really long time, so if I don't now, it's not going to happen.
Yeah, I would agree with that. So you will receive an email in the next couple of days, a reminder. It'll have all of this great contact information. The colleagues as well that are listed here will be listed in your email. You'll receive a recording as well as slides. And there are a few other orthopedic surgery locations throughout Wayne, Oakland, and Washtenaw County. So we'll share some of those locations as well. And
they're almost as fun as us at the Livonia Medical Center. Almost as fun.
Almost as fun. That's right. So if you do you need a referral to see a physician such as yourself?
It kind of depends on the insurance, to be honest with you. A lot of insurance plans do not. Certainly calling the appointment line, Ortho IHA, we can help answer that question. A lot of times, if we do need a referral, we can get it sort of retroactively, meaning we can help reach out. And even if we see you that day, we can help get it to go through so there's no issues.
Yes, we definitely have wonderful staff at all these practices as well. And they're very well versed in all things insurance and billing and all of that good stuff. So they will help you work through those questions. So don't be afraid to call, give it a try. And Dr. Aalderink is accepting new patients. Yes.
Absolutely.
Okay. All right. So thank you so much. We appreciate your time, your expertise, and your dad jokes.
Perfect.
All right. Have a good evening, everyone.
Thank you, everyone.
Yep. Bye-bye.